Hi everyone. Today we're going to discuss the topic that is not always talked about and sometimes ignored and pushed under the rug. Eating disorder come in many varieties, and today we are going to learn how we can help ourselves and help our patients to maintain health. So what be healthy means? Behavioral evaluation of healthy eating leading to a healthier you. My name is Larissa Biznichuk. I'm the Director of Secondary Eating Recovery Program at Sierra Tucson Addiction and Mental Health Rehab Facility. I will be presenting this topic with my colleague, Danielle Hendricks, lead registered dietitian at Sierra Tucson. Together, we will give you an overview of how to identify and refer your patient to obtain the right help. Please prepare your questions. We will have Q&A at the end of our presentation. Well, now I'm going to turn off my camera and we will all focus on our presentation. I will turn the camera back on at the time for Q&A. All right. So let's begin. Here's our agenda. We will be talking about classification of eating disorder, how to identify patients with eating disorder, DSM-V diagnostic criteria, orthorexia, and the team approach of treatment of eating disorder. Our learning objectives. By the end of this presentation, you will be able to define the different type of eating disorder, their symptoms identifiers. Also, we will talk about the difference between eating disorder and disordered eating, describe the benefits of multidisciplinary team approach of treatment of eating disorder. I can tell you right now that identifying and diagnosing eating disorder is very difficult in our current society of diet culture. Eating disorders do not discriminate. According to the National Institute of Mental Health, eating disorders victims are people of all genders and sexual orientations, all races and ethnic backgrounds, all cultural and all religious backgrounds. I think our society is challenging. We see more and more young adults, different genders, colors, and ethnicities coming to our facility, asking for help with eating disorder. Well, can you tell by looking at the individuals if they have eating disorder? It's hard to tell. We have our genetic predispositions to different body type, medical diagnosis. We have different body shapes. Some of us are taller or others are shorter. In primary care setting, we're focused on patient's physical health, and consequently, eating disorder is not an obvious diagnosis. We see overweight people, and immediately our recommendation will be, you need to lose weight. You're at risk for diabetes, for metabolic issues. Accidentally, we can trigger their eating disorder mind. What can we do different? Before we answer this question, let's identify what is an eating disorder and if there is a difference between eating disorder and disordered eating. What can be called eating disorder? According to DSM-V, its Diagnostic and Statistical Manual of Mental Health Disorders, feeding and eating disorder is a persistent disturbance of eating or eating-related behavior that results in altered consumption or absorption of food that significantly impairs physical health and psychological functioning. Eating disorder behaviors can be very different for any particular individual. It can include purging, restricting, binging. Those are the most obvious ones. There is purging through exercise, laxative abuse, diuretic abuse, fear of eating unhealthy food, fear of swallowing food, fear of choking. With eating disorder, consumption of food is altered, including consuming not enough food, consuming nutritionally insufficient food, excluding important food groups like fats or carbohydrates, or opposite, eating a lot of proteins. All this action can definitely affect metabolism and absorption of nutrients into a chemically balanced body. The disruption of this balance can result in physical and psychological impairment. All right, so let's talk about what can trigger eating disorder. Eating disorder is mental health disorder, which can result into a very complicated medical issues. Often eating disorder is a compensatory mechanism which people develop to help them to deal with their emotional dysregulation related to trauma, depression, anxiety, addiction, insomnia, low self-esteem, relationship issues. Well, in my practice, I see many people who develop eating disorder to gain some control of their emotions. For example, trauma, sexual abuse, gaining weight to be less attractive, or losing weight to be more invisible. Our society is promoting the false belief that weight loss is the way to improve our self-esteem and self-worth, sometimes to avoid criticism. We fear being vulnerable and are unable to talk about our problems because it might show our weakness, which will lead to rejection by our loved ones, peers, or society. This in itself can re-traumatize an already emotionally dysregulated individual. We must be skinny in order for us to be attractive. Well, how many of us have this experience where our loved ones would comment on our body shape, weight, or how much we eat? In most cases, they just want to be funny or to help you to change so you feel more accepted, or just because they don't want you to feel bad about yourself when you grow up. Let's talk a little bit about the statistics. So what are the statistics for eating disorder? Gender. More females than males are presenting with eating disorder. 50% of teenage girls and 33% of teenage boys are engaging in unhealthy weight control behaviors. Bullying, criticism of being overweight. Competitive sport coaches are enforcing weight and physique criteria for our athletes. Frequently, eating disorder starts with just normal dieting, portion control, balanced meals, then become more strict and more structured, leading to development of eating disorder. Many athletes develop orthorexia. Danielle will talk a little bit more about it. While I was reviewing materials and studies for this presentation, I came across a wide variety of statistics. It was very interesting for me to see the different sample population and results. Looking through the data supports my idea that eating disorder recognition and understanding is it's in a very early stage of development. I'm very happy to report that in our practice, we see more and more people who are open to discuss their difficulties with body image and nutritional intake. We see a lot of males who would like to know more about eating disorder and who would like to learn to identify their own. With this curiosity comes the willingness to address their disorder and make changes. If time allows, maybe we can talk about varieties and eating recovery program at the end of our presentation. How can we identify eating disorder? Well, with speaking with my colleagues in primary care, they often express the challenges of identifying eating disorder. People who are struggling with eating disorder are not always forthcoming. They also may have very limited understanding of their behaviors. Remember, our culture is promoting healthy diet, weight loss, physical activities with high endurance. We as healthcare workers are not always able to identify our own difficulties and our own biases as well. What we learn in medical and nursing schools cannot always be applied directly to our real practice. When we see our patients, we need to see them as a whole and not just conduct symptom-focused assessment. Our diet-oriented society is promoting the false belief that weight loss is the way to improve our self-esteem and self-worth. How many popular diets can you name now? Well, let's start with keto diet, which was originally suggested for treatment of seizures, low-fat diet, low-carb diet, intermittent fasting, Atkins diet, 28 days diet, anti-inflammatory diet. The list can go on and on. Our primary care providers and endocrinologists are concerned about physical health and effects of obesity on our body. But why don't we take a moment and ask, are there any mental health behavioral difficulties this patient is struggling with? One of the topics that concerns me is the weight loss surgeries. How much mental health support are we providing for those people who undergo those procedures? Are primary care providers in contact with their psychiatric providers? Do those patients have psychiatric providers? Or do we know? I was asked on several occasions to do a psychiatric evaluation for patients undergoing weight loss surgeries. When I asked the patient if they are going to continue working with a mental health professional after their weight loss surgery, patients would say no. My doctor said, I just need to lose weight. The reason being that they are not going to have the knee pain or their back pain will be a little bit better. Their diabetes and cholesterol will be more under control. I'm sure this is not the message which our primary care providers are trying to convey to our patients. But sometimes that's what our patients understand and hear. I always try to reach out to a weight loss specialist to establish continuity of treatment. So what are the most commonly diagnosed eating disorders? There are a few different specific diagnoses of eating disorder. More commonly recognized are anorexia nervosa, bulimia nervosa, binge eating disorder, and unspecified feeding and eating disorder. In my practice, I very rarely see one or the other diagnosis. More often, we see a combination of those diagnoses. Some individuals start with behaviors of anorexia nervosa, then process to bulimia or binge eating disorder or vice versa. There is also a stereotypical view of anorexia nervosa. Patients must be skinny. However, it's not always the truth. Patients with anorexia nervosa not always severely underweight or not always obviously skinny. Some of them are at normal or nearly normal body weight. Patients with normal or nearly normal body weight with symptoms of anorexia nervosa are diagnosed with a typical anorexia nervosa. Individuals who are suffering from bulimia nervosa have normal weight most of the time. Well, so let's be specific. Let's talk about anorexia nervosa. Per DSM-V, anorexia nervosa is restriction of energy intake relative to requirements, leading to a significantly low body weight in context of age, gender, developmental trajectory, and physical health. Intense fear of gaining weight or becoming fat, or persistent behavior that interferes with weight gain, even though they are at significantly low weight. Disturbance in the way in which one's body weight or shape is experienced. Persistent lack of recognition of the seriousness of current low body weight. There are a few subtypes. One is restricting type and the other one is binging purging type. Then let's talk about bulimia nervosa. Repeated binge eating followed by recurrent inappropriate compensatory behavior in order to not to gain weight. It can be self-induced vomiting, laxative abuse, diuretic abuse, use of weight control medications, excessive exercising. They have an unrealistic fear of weight gain. Self-evaluation is unduly influenced by body weight and body shape. The disruption does not occur exclusively during the episodes of anorexia nervosa. All right, the next one is binge eating disorder. It's a recurrent episode of binge eating in a discrete period of time, let's say 2 hours, an amount of food which is larger than what individuals who have eaten, the amount of food which is larger than what most of individuals, right, would eat in the same period of time under similar circumstances. A sense of lack of control over eating during the episode. The binge eating episode are associated with 3 or more of the following: eating more rapidly than normal, eating until uncomfortably full, eating large amount of food when not feeling physically hungry, eating alone because of feeling of embarrassment by how much they eat, feeling upset with themselves, depressed or guilty after the binge eating episode. The next one is going to be unspecified eating disorder. This diagnosis applies if symptoms characteristic of feeding and eating disorder that cause clinical significant distress or impairment in social, occupational, or other important areas of functioning predominate but do not meet full criteria for any of the diagnoses in feeding and eating disorder diagnostic classification. In my opinion, many of our individuals meet criteria for unspecified feeding and eating disorder. Very often, patients are substituting one behavior with another. For example, if they are not able to purge because of their new environment, they might start over-exercising or using laxatives or start restricting. All right, let's talk a little bit about outcomes of eating disorder. Let's start with anorexia nervosa. Anorexia results in harmful health effects such as brain damage, multi-organ failure, bone loss, heart problems, infertility, the risk of death is the highest in individuals with this disease. Bulimia has injurious effects and consequences as well, such as gastrointestinal problems, severe dehydration, and heart problems resulting from electrolyte imbalance. Binge eating disorder can lead to increased risk of obesity and development of other conditions such as cardiovascular disease and diabetes. Well, unspecified feeding and eating disorder cause clinically significant distress or impairment. The outcomes of different eating disorder diagnoses might be very similar at the end. Significant effect on physical health. Red flags. Body mass index, BMI. Identifying severity of eating disorder. BMI is a screening tool to identify weight category: underweight, healthy weight, overweight, or obese. It cannot be used for diagnostic, only as a screening tool. My slides only reflect the critical numbers for underweight individuals. The healthy BMI consider ranging from 18.5 to 24.9 kilograms per square meters. Overweight, 25 to 29.9 of kilograms per square meters. How to calculate BMI? You take weight in kilograms, divide by the square of height in meters. Pounds and inches can be used too. You can absolutely use very quick reference online to calculate the BMI. That's the easiest way to do it. All right, so we talked about more commonly seen feeding and eating disorders, but there are a few more. PICA, which is consumption of non-nutritional, non-food items and substances. The compulsive eating non-food items can be from non-harmful ice eating to more harmful and dangerous pain consumption. People who are more at risk to develop PICA disorder are people with iron deficiency anemia, malnutrition, pregnancy, when body is trying to correct the deficit of nutrients. PICA usually can be resolved with supplementation of nutrients, vitamins, and minerals. Rumination disorder is regurgitating food back up from stomach to be rechewed, reswallowed, or spit out. The process of regurgitation usually is very effortless for people. It is not an act of intentional purging, which we can see in anorexia and bulimia nervosa. There is no pharmacological treatment of rumination disorder. Treatment is all based on therapy, behavioral modification, and breathing exercise. Next one is avoiding restricting food intake. Our feet. We call them picky eaters, which is only partially true. The symptoms of this disorder are very much similar to anorexia nervosa. People restricting an amount and type of food they eat. But how we can differentiate those two? People with RFID are not worried about their body image, size, or shape. People with RFID do not eat enough calories for proper functionality of their body. They are more sensitive to the taste or texture of food, might have had bad experience with food, like choking, vomiting, so they become fearful and anxious about food. The best treatment for ARFID is the multidisciplinary approach, which nutritionist, therapist, medication, cognitive behavioral therapy. What primary care providers should be aware of, and when to consider eating disorder as a primary diagnosis. In my opinion, especially now, when our society is more focused on healthy lifestyle, the idea of healthy lifestyle can be taken to the extreme. We should be aware and open to discuss possible eating disorder. Our patients might not even be aware of their unhealthy behavior. For example, some people are emotional eaters. When they are coming home for a stressful workday, they try to improve their mood by indulging in a large amount of food and sweets. Then their stomach feels upset, so they go and vomit the extra food. This becomes a pattern. We won't know about it till we ask, right? What are your coping techniques for stress? What do you do when your work environment becomes so stressful? Often when I see patients with excessive weight, I ask about stressors and coping techniques while assessing physical symptoms. So when should we consider assessing our patients for eating disorder? I would say at all times, but more specifically, if a patient is otherwise healthy, all diagnostic testing have ruled out possible medical issues, but patients still have brady or tachycardia, lightheadedness, syncope, palpitations, gastrointestinal issues like irritable bowel syndrome starting at a very young age, unexplained diarrhea or constipation, or feel bloating. In otherwise healthy, not pregnant female, missing menstrual cycle for more than 2 months. Cold intolerance, dry skin, hair loss with no detected thyroid issues. Well, this is the end of my presentation. I will turn the microphone to my colleague Danielle Hendricks to continue our discussion on eating disorder. We do have a case study which we would like to talk to you about. If we have enough time at Q&A, we can definitely do our case study. Thank you very much. And now I'm going to turn the microphone to Danielle.
All right, hello everyone. I'm turning on the webcam for just a moment so you can see my face. Again, my name is Danielle Hendricks. I'm the lead registered dietitian here at Sierra Tucson. I'm going to be talking a little bit about the difference between disordered eating and eating disorders, orthorexia, and what it's like to work in a multidisciplinary team for the treatment of eating disorders. So now my camera's going to go back off. Okay, there we go. So first, I'm going to start with defining the difference between eating disorder and disordered eating, because there is a very important difference between the two. When I use the term eating disorder, I'm referring to an official diagnosis from the DSM-V and listing off the ones that Larissa already discussed: anorexia nervosa, bulimia nervosa, binge eating disorder, pica, rumination disorder, etc. Disordered eating, on the other hand, is not an official diagnosis. Instead, it's used to describe a range of irregular eating behaviors that may not necessarily warrant a diagnosis. When I'm teaching my clients and my colleagues about disordered eating, I refer to it as the gray area of eating disorders, meaning someone may exhibit some characteristics of an eating disorder, but it may not be quite as severe or frequent enough as someone that fits the quote unquote check marks of an eating disorder. As you can see, some individuals with disordered eating may be diagnosed with unspecified feeding or eating disorder. However, there is a caveat to this. There are still some specific criteria that must be met in order to receive this diagnosis. This can be problematic to the client in the sense that some individuals may feel discouraged from seeking help because they do not think their disordered eating behaviors are severe enough. Some individuals may even take advantage of them not being sick enough, essentially, to be diagnosed, which can further fuel the normalization of their disordered eating behaviors. Which leads me to my next slide. Eating concerns falling short of a diagnosis still deserve attention and treatment, as they may turn into more problematic eating disorders. This quote really stood out to me, and I felt that it deserved its own slide. I have seen several clients over the years where I'm one of, if not the first clinicians to point out these red flags for eating disordered patterns. So what are some of these red flags? Frequent dieting. That can range from intermittent fasting to the keto diet. Larissa had pointed out a few earlier, the Atkins diet, the Whole30, calorie counting. The list goes on and on and on. There's no shortage of different diets that people are coming up with these days. Anxiety associated with specific foods or food groups. I've noticed that there has been a shift over the past couple decades in what diet culture and society has deemed to be good versus bad. In the 90s, fat was considered the enemy. Today, it seems to be carbohydrates and starches in particular. And it's unfortunately very common to see many clients stating that they're trying to limit or even avoid carbohydrates entirely. Chronic weight fluctuations. Weight history, as Larissa had discussed earlier, is a very important factor and tool in assessing eating disorders and malnutrition. Yes, those that are underweight, meaning that they have a BMI or body mass index of less than 18.5, that's going to be a red flag. However, it is entirely possible for someone in a bigger body, meaning that they're overweight or obese, to be diagnosed with anorexia nervosa and or malnutrition. As a registered dietitian, I'm looking at their usual body weight, so what do they consider to be stable, what has been their highest and lowest weight as an adult, and any notable weight fluctuations. For example, if I hear that someone has lost 5% or more of their body weight in about a month's time or so, that's an automatic red flag. And I also want to say, I do recognize that there can be many, many reasons for weight fluctuations, not just intentional or eating disorder related. And this is why I'm taking into consideration medical history, medication use, any recent procedures, anything and everything that can contribute to weight. Rigid routines around food and exercise. I bolded the excessive exercise in particular. I find that this is another aspect of diet culture and in society where excessive exercise, going to the gym all the time, doing bodybuilding, it's become so normalized. When in reality, we do recognize this as a potential sign of purging, like Larissa talked about. And this can put the individual at risk for serious medical complications, decreased bone density, not getting enough nourishment to their bodies, possibly passing out or feeling lightheaded or dizzy. Other signs and symptoms include feelings of guilt or shame with eating, especially with the foods that they have labeled to be bad or unhealthy. Preoccupation with food, weight, body image. It's been said that those with anorexia nervosa in particular are thinking about food 90, 100, up to 110% of the day. And I say 110% because they might be sleeping and dreaming about food. So just constant thoughts about food, weight, what is their body looking like, as well as a feeling of loss of control around food, especially including compulsive eating habits with our binge eaters and our people with bulimia. Okay, now I'm going to talk a little bit about orthorexia. So orthorexia is not an official diagnosis. It's not recognized by the DSM-5. There's also uncertain etiology, and unfortunately, we do have pretty imprecise assessment tools. So what we do know about orthorexia is that this affects approximately 6.9% of the general population, and we've also found that it can occur more frequently in healthcare professionals as well as performance artists. Think like actors, musicians, ballet dancers, etc. So what is orthorexia? Orthorexia is a focus and for some, quite frankly, an obsession on quote unquote healthy eating. And I use quotes around the word healthy because I have found that this term is very subjective, depending on who you're talking to. Some may define healthy as being organic or raw or vegan or green or low carb, who knows? It really depends on who you're talking to. Those with orthorexia will have emotional distress towards the foods that they have defined as unhealthy. And I've actually done away with using the terms healthy, unhealthy with my clients, just because it does create a distorted view and thus a negative relationship with food. I also want to point out that weight loss may occur with those that have orthorexia, but it's not usually the primary goal. So what's the big deal with orthorexia? I always get this question from many individuals asking me, how do you view healthy eating as a bad thing? Which again, I love this quote so much, so I felt it deserved its own slide. Despite a focus on eating, orthorexia may lead to malnourishment, loss of relationships, and poor quality of life. With orthorexia, dietary restrictions will escalate over time and may result in eliminating entire food groups. A prime example could look like starting with cutting out desserts, then expanding to processed foods, breads, then eventually a severe limitation or elimination of processed foods or starches altogether. It can also look like more frequent and or severe cleanses, fasts, in order to purify or detox the body. This may be the result of someone eating something that they have deemed unhealthy or bad. And as a registered dietitian, this is something I would never recommend to a client. Like I mentioned before, weight loss, malnutrition, or other medical complications can result from this limited or restricted diet. And along with the medical complications, the individual with orthorexia can also develop intrapersonal distress with social, academic, or vocational functioning from their beliefs. This is especially true in the social aspect, as someone with orthorexia may choose to go without eating at all if they're going to be going to a restaurant, a friend's house, if they deem that the food that's going to be served is unhealthy. All right, switching gears a little bit, I'm going to briefly talk about working in a multidisciplinary team for eating disorders. It is crucial to have a team with helping to solve an eating disorder, as no one profession can do it on their own. And depending on the severity of someone with an eating disorder, they may require some or all of the following clinicians. So here is what the treatment team may consist of. It will consist of a physician. So this may be the client's primary care provider, or this can include a specialty doctor if the client has GI complications, such as IBS, heartburn, or slow gastric emptying, as well as like endocrine issues as a result from their eating disorder. Certainly you'll want a psychiatrist to manage any kind of psychoactive medications, a registered dietitian, preferably one that does have some background or even specialty in eating disorders, to tackle the medical nutrition therapy, nutrition rehabilitation, and nutrition counseling for eating recovery. Of course, a therapist to address the underlying issue, because we know that the eating disorder is not about the food itself. The therapist can be an individual therapist, a family therapist, group therapist. I have worked with many clients that see multiple therapists, one that specializes in eating disorders, one that's a family therapist. The possibilities are really endless. Depending on the severity, like I said, with their eating disorder and or the malnutrition, the client may need to see a dentist for damage control or repair, especially if there is purging going on or tooth loss. A physical therapist if there is decreased bone density from prolonged restricting, and a speech pathologist to help with feeding and swallowing. Okay, so when working with a team, like I said, it's crucial that there is an open line of communication between the providers to discuss the client's progress in treatment. What we don't want to do is rely on the client to communicate the recommendations of the different providers. What we do want to let the client know is when we will be communicating with other providers. I don't want it to feel to the client that it's a secret or I'm going behind their back to talk with their therapist. I want to be as open and transparent with my client as possible. Of course, I want to make sure that I'm doing this legally by getting a release of information signed, especially if you're not working in the same building as the other team members. But even when the client has already signed an ROI, I still want to give them a heads up about communication between the providers. And the recommendation should be consistent across the board. So, like I said, communication is crucial for evaluating progress and readiness to change, if there are any medical or safety concerns, obstacles to treatment or getting better, and also discussing the need for transitioning to a higher or lower level of care. So seeing someone outpatient where they are struggling a little bit too much and they need more support than what each of us can offer at this time, we might have to have that difficult conversation of recommending that they go to an intensive outpatient program, a partial hospitalization program, a residential treatment center. It really, really depends. Okay, I'm going to briefly mute the mic and pass it back to Larissa, who is going to go over the case study.
All right, I'm back. So here is our case study, right? We will be talking about Molly, who is 18 years old female, brought to our treatment facility by her parents. For the past 4 months, she lost 25 pounds. She's a college student, recently moved out of her parents' home, living at the dorm with her classmates. She started complaining about difficulties with concentration, dizziness. At first, her parents blamed it all on schoolwork and final exams. Over the summer, she moved back with her parents, and that's when they noticed the change in her behavior. She's avoiding family meals. When asked to have meal with her parents, she would say that she's fatigued, not hungry, her stomach is upset. She's exercising daily, leaves home early in the morning, and comes home 3-4 hours later from the local gym. Her vitals, from what you can see, is within normal range except her BMI, right? And we remember about our BMI chart. So it's pretty significantly underweight. She uses laxatives. She's taking 3 pills a day for the past 3-4 weeks to attempt to have the bowel movement. But in her words, it's not really works. Her bowel movement still infrequent and with intervals 10 days. Her friends are supportive of her losing weight, praising her by telling her that she looks very attractive. So what diagnosis we will give her? And I'll let Danielle participate in that too if we want to talk about the multidisciplinary team approach. She's using quite a few different, eating disorder behaviors. She's over-exercising, which can be considered purging through exercise, and she's restricting her nutritional intake. So as I talked before, it's very hard to pinpoint, well, this is exactly the bulimia or this is exactly the anorexia when the patient, there is no, consistent see the patient. It's our first time meeting patient. So the behavior is changing. So the diagnosis which we gave her was unspecified feeding and eating disorder. Although her BMI was pretty much suggesting anorexia. What treatment are we going to do? She's in residential facility. She was in residential facility, right? We're restoring her weight, so making sure that her BMI is increasing so she can continue working on her mental health issues, which can be the anxiety, the relationship between her classmates or whoever, people supporting her while she's in school, making sure that her self-esteem is at the right level so she can talk about, with her classmates, talk about the unhealthy behaviors which they are promoting.
And A couple of things that I noticed, some of my red flags that were going off as Larissa was presenting this case study. Immediately, my eyes are looking at the amount of weight loss in a significant period or short period of time. So a 25-pound loss where she's about 100 pounds now, I quickly calculated that and it looks like she's lost over 20% of her body weight. So that is very, very concerning, regardless if she was at a BMI of 16.5 or if she was at a BMI of 29, it doesn't matter to me. Um, as a dietitian, one of my primary role, number one, is to keep her safe while I am working with her to restore her nutritional intake. So that is going to look like weight gain, yes. I would absolutely want her to be working with a therapist and a medical, a psychiatric provider to make sure that is she medically safe, but also how is her mental health? How is she able to cope or deal with the fact that she does need to weight restore? Because it's going to be very, very triggering for her, quite frankly. It's going to be very, very difficult for her. And as the dietitian that is promoting that she weight restore, I will likely be seen as the enemy to her, and that's okay. I want to make sure that she's safe, and I also want to make sure that I'm working with her and not making it feel like I'm working against her.
All right. So I would like to turn on our camera and maybe we can talk a little bit about the questions which we received. All right, here we are. No, I think it's hidden. Oh, let's figure it out. All right, here we are. So there was a question about the blood type diet. As we talked, there is a lot of diets which people can come up with, and with some support of science to it, we absolutely can say that yeah, it might be working for some people, but diet in general probably not the best approach of um, staying healthy and be able to live productive life, because when you're dieting there is as we talked, there is a chemical balance in our body, and when we're excluding some nutrients, we're excluding some chemicals which can lead to disbalance and which can be very traumatizing for our body.
For sure. And also to add along to that, like Larissa said, there's so many different types of diets out there. I find that more clients are telling me about whatever the latest trend is. Whenever I'm giving nutrition counseling, nutrition recommendations, I try to be as individualized as possible. So I tell people, even when I'm teaching about general guidelines such as my plate or incorporating variety, I say my recommendations and interventions are specific to you. What I'm telling you, it may not be what I recommend for another person. So that's another tricky thing with diets, is that if you read something from the internet, a book, whoever really, they don't know you as the individual. So that's why you want to get that specialized care. That way you, because that's what the individual deserves.
Absolutely, absolutely. There is a reading which I really want to recommend for clinicians, even for patients. Give me a second. We're going to find the book, right? So this is the book. It's called Sick Enough by Jennifer Gaudiani. Great book to have it as a reference, to have it as a maybe discussion with our patients when when they're struggling, when they're not recognizing that whatever they're experiencing is too dramatic, or they're not too sick to, pay attention to those little things. They're functioning well. Yeah. So this is the end of our presentation. We really appreciate your time. We do have the email available. So if you do have any questions, if you do want us to, talk a little bit more about the eating disorder, or giving us suggestion, what are we going to do the next time we all meet and do our little webinar together? So let us know. We're open for suggestions. Yeah, here's a reference list if you want to take a peek at it. And thank you very much all. Hope you all have a great day.
Yes, thank you.